Mm. We have already discussed jugular venous pulse and their different waves. Now, today we will discuss with arterial pulse and different ECG recording also. So arterial pulse, there are different types of arterial pulse. One is pulsus parvus et tardus. Pulsus parvus et tardus is seen in aortic stenosis. Aortic stenosis. Pulsus alternans is seen in left ventricular failure. Pulsus bisphaerian, collapsing plus slow rising associated with aortic regurgitation with or without accompanying aortic stenosis. And it is also found in hypertrophic obstructive cardiomyopathy. So pulsus bisphaerian, aortic regurgitation, and HOCM. Now dichrotic pulse found in dilated cardiomyopathy. So pulsus bisphaerian found in obstructive hypertrophic obstructive cardiomyopathy and dichrotic pulse dilated cardiomyopathy due to very low stroke volume. One is Jarki pulse, also found in HOCM, severe mitral regurgitation. So important is collapsing or water hammer pulse. Very important is aortic regurgitation, patent ductus arteriosus, and any hyperdynamic circulation. Pulsus paradoxus. It is found in cardiac tamponade. Pulsus paradoxus, cardiac tamponade, constrictive pericarditis, and COPD, COPD or superior vena cava obstruction. So these are the different types of pulse. In the detail, you will see the detail, but we just discussed what are the causes of these different types of pulses. Now coming to the heart sounds. Very important. S1, S2 is the common sound. S1 is due to mitral and tricuspid valve closure. S2 is due to aortic and pulmonary valve closure. So there is S3 and S4 also. Now S3 is from ventricular valve due to abrupt cessation of rapid filling. S3 may be a physiological or it found maybe in young. In pathological condition, there may be heart failure or mitral regurgitation. So S3, S1, S2, S3. S4 due to high atrial pressure. One thing is very important that S4 is always pathological. S3 may be physiological, but S4 is always pathological. It associated with severe left ventricular hypertrophy like HOCM or absent in atrial. S4 absent in atrial fibrillation. So S4 is always pathological. S3 due to maybe physiological or pathological in heart failure. So these are the components of heart sound. Now it is not necessary to see that heart murmurs because it is a big chapter. So we come with the different electrocardiogram. Okay. Now, one thing is that in murmur, the basics of this systolic murmur and diastolic murmur, one is continuous murmur. So, continuous murmur are not confined to either phase of the cardiac cycle, but it begins in early systole and proceeds through S2 into all parts of the diastole. So, there are different grades of murmur. So, intensity, according to intensity of the murmur, the grade is 1 to 6. Now, grade 1 murmur is very soft and is heard only with great effort. Grade 2 murmur is easily heard but not particularly loud. Grade 3 murmur is loud but not accompanied by a palpable thrill. And grade 4 murmur is very loud and associated with a thrill. Grade 5 murmur, loud enough to be heard with only the edge of the stethoscope touching the chest. And grade 6 murmur is very loud. It may be heard with the stethoscope slightly off the chest. So these are the 6 grades of murmur. So nothing about systolic murmur and diastolic murmur. There is mid-diastolic murmur. So different condition will, whenever we discuss about the different condition, we say that the mid-diastolic and different types of murmurs, name Carey-Coombs murmur, Graham-Still murmur, and all these Gibson murmurs, we will discuss later on. So Let us come with a very important chapter, electrocardiogram. Very important. Now, electrocardiogram is very important because so many electrical activities of the heart can be uh, mm, diagnosed with the electrogram. Like resting, there may be resting ECG, electrocardiogram, or there may be treadmill test. So, basics of electrocardiogram, there is 12 conventional ECG leads. 12 conventional leads. Uh, these leads are divided into two groups: 6 limbs leads and 6 chest leads. So the limb leads records potential transmitted onto the frontal plane, and the 6 limbs lead to further subdivision: 3 standard bipolar leads, 1, 2, 3, and 3 augmented unipolar leads, AVR, AVL, and AVF. So each standard bipolar leads we set in different conditions. There's a lead 1, record a left arm and right arm voltage; lead 2, left leg and right arm voltage; and lead 3, left leg and left arm voltage. So the right leg electrode function as a ground. Right leg electrode function as a ground. Now 6 chest leads, V1 to V6. The V1, we put this frontal fourth intercostal space just to the right to the sternum. V2 will enter the fourth intercostal space just to the left of the sternum. V3 midway between V2 and V4. And V4 is mid-clavicular line, fifth intercostal space. V5 anterior axillary line, same level as V4. And lead 6 maxillary, mid-axillary line, same as V4 and V5. So mid-axillary line, 5, 6, and 7. So these are the 6 lists we can put it. Now, what are the normal ECG recording? Normal ECG recording, there are different types of waves. So first is the P waves. P waves is due to atrial depolarization. PR interval, it is the conduction through AV node. PR interval is less than 0.2 second. QRS complex due to ventricular depolarization. It is less than 0.12 second. Now, QT interval is mechanical contraction of the ventricle, and T wave ventricular repolarization. ST segment isoelectric ventricular contraction, and U wave there may be Purkinje repolarization or caused by hypokalemia and bradycardia. So these are the normal ECG record, tracing record: P, Q, PR, QRS, QT, T, ST, and U waves. So these are the things. Now in examination we may ask that what is the normal PR interval? So normal PR interval is less than 0.2 second, and normal QRS complex less than 0.12 second. Okay. So in some conditions there is increased PR interval, so there is first degree, second degree, third degree heart block will come later on. Okay. So now how we calculate the heart rate in ECG? The ECG paper moves 25 small squares in 1 second. So speed is 25 millimeter per second. In other words, it moves by 25 into 60, that is 1500 small squares in 60 seconds, that is 1 minute. So if the distance between two successive QRS complex, that is RR interval, is measured, the number of ECG complexes in 1 minute will be 1500 divided by that number. So that gives the heart rate, heartbeat per minute. So this is a simple way of calculating the heart rate. Now coming to the, we have seen the normal ECG tracing. Now what are the conditions where we got abnormal ECG? Abnormal ECG is very important, and you have to study repeatedly to know what are the different abnormalities in ECG tracing. So number 1, the most common is that hypercalcemia, hyperkalemia, these are hypothermia. So all are the different seen in the ECG tracing. So in hyperkalemia, that is increased potassium level. Hyper, that means hyper means tall. Tall tented T wave, we find it tall tented T wave, decreased P wave amplitude, QRS may be wide, and this is known as sine wave pattern. Sine wave pattern. So In hyperkalemia, tall tented T wave, side decreased P wave amplitude, and QRS widening of the QRS. So it is known as sine wave pattern, SINE, sine wave pattern. Okay. Now, just opposite hypokalemia, decreased potassium level. So there is prominent U waves, and there may be small T wave, maybe ventricular bigeminy, and pseudo P pulmonale. So that you see that दोनों difference. दोनों hyperkalemia and hypokalemia. In hyperkalemia, tall tented T wave, here is small T wave. There is a decreased P wave amplitude. There may be pseudo P pulmonale, that is increased P amplitude. So there may be ventricular bigeminy and another prominent U wave you will see. So in examination asks, what are the causes of U wave in ECG? So hypokalemia. Now hypercalcemia, just hypercalcemia shortened QT interval, and hypokalemia lengthen QT interval. Simple way. Shortened QT interval in hypo lengthen QT interval. Now what are the conditions you get what are the things you get in subarachnoid hemorrhage? Now subarachnoid hemorrhage, there is marked QT prolongation with deep wide T wave inversion. Marked QT prolongation with deep wide T wave inversion, and this is known as CVA-T wave. So very important in subarachnoid hemorrhage, marked QT prolongation with deep wide T wave inversion. In case of hypothermia, there may be convex elevation of J point, J wave on this ECG tracing, and there may be is convex elevation. So what is J wave? It is just you see the ECG tracing. There is QRS. So RS के बाद जो होता है elevation, that point is known as J point. So J point, there is convex elevation of J point or J waves. You can see in hypothermia. So it is also asked in the examination that what is convex elevation of J point or Osborne waves. You see in hypothermia, and another syndrome is known as Brugada syndrome. We'll come later on what is Brugada syndrome. So these are two conditions in which you get elevated convex elevation of the J point. Now what happened in pericardial effusion? So pericardial effusion, there is I think there is some hampering of the cardiac impulse. So it is known as total electrical alternance, often with tamponade. Total electrical alternance often seen with tamponade. Okay. Now what are the effect of digitalis toxicity? It is also asked in examination, what is the effect of digitalis toxicity? So there is shortened QT interval with a characteristic scooping of the STT wave complex. There is prolongation of PR interval, inverted T waves, or you say that inverted check mark sign in V5, V6. So three important findings: shortened QT interval with characteristic scooping of the STT wave or ST depression, PR prolongation, and inverted T wave known as inverted check mark sign. So digitalis toxicity. Now what happened in different syndromes, like syndrome associated with prolonged QT interval? There are the two different syndromes, Romanov-Gerd syndrome. So you need not know this. Now, what is right ventricular bundle branch? Right ventricular bundle branch. क्या मिलेगा इसमें? तो most common right bundle branch is most common than left bundle branch block. So it occurs with heart disease, maybe congenital, ASD, or acquired by valvular or ischemic heart disease. So right ventricular and left bundle branch block is often a marker of one of the four underlying conditions. Very important. Left bundle branch block, right bundle branch may be physiological, maybe heart young, maybe it may be in congenital or some valvular ischemic disease. But left bundle branch block is a marker of one of the four. Number one is ischemic heart disease. Number three, long-standing hypertension. severe aortic valve disease, or cardiomyopathy. So these are the four conditions. You get left bundle branch block. So four conditions: ischemic heart disease, long-standing hypertension, aortic valvular disease, severe, and cardiomyopathy. Now, what is P pulmonale and P mitral? This is also important. Now, P mitral. So mitral stenosis is the most common rheumatic heart disease one. So in P mitral, what happened? There is broad notched P wave, M pattern. Mitral M, so M pattern, with a duration more than 0.12 second. So this is important. Broad notched P wave with a duration more than 0.12 second, indicating left atrial enlargement, and that is commonly associated with mitral stenosis. So there is increased duration of PUF. That's why it is called P mitral. So notched or M pattern biphasic, duration more than 1 2 second, caused by mitral stenosis. So left atrial enlargement. Second is P pulmonale. Now P pulmonale is tall peaked P wave. It is more than 2.5 millimeter tall peaked P wave, associated with right atrial enlargement and COPD. So tall peak P pulmonale is tall peaked P wave more than 2.5 millimeter, associated with right atrial enlargement. So these are the waves we can see abnormality in the ECG tracing. So if you see different pictures in your textbook, and you verify these all things.
Yes.
Okay.
When the Google images of the pictures are very important because क्वेश्चन पेपर जब बनता है तो गूगल की इमेज जो होता है बहुत कॉमनली जो दिखता है ना उसको भी वो लोग डालते हैं लाइक स्टैंडर्ड टेक्स्ट बुक का भी
नहीं,
डालते
उसको
हैं गूगल इमेजेस भी क्वेश्चन
उसमें
पेपर में रहता है
उसमें पिक्चर दे देगा, उसमें ECG ट्रेसिंग दे देगा और बोलेगा डायग्नोज द केस, और बोलेगा कि वो जो है हाउ यू ट्रीट द पेशेंट, व्हाट इज द ड्रग ऑफ चॉइस ऑफ दिस कंडीशन.
राइट राइट
Yes, it is important. So we come different diseases. This is inverted effect of digital toxicity, inverted tick mass, STT depression. Okay. M pattern is P mitral, tall P waves in P pulmonale, and other conditions also coming. Now, let us come with axis deviation. Axis deviation. So normal axis, QRS axis range from -30 to 100. Left axis deviation, the axis more negative than -30, and right axis deviation positive more than 100 plus. So what are the conditions in which you get left axis deviation in case of right axis deviation? So left axis deviation normal variant हो सकता है. Left axis, that means left ventricular hypertrophy, more common, left ventricular hypertrophy. So whenever there is increased tissue mass, increased muscular thickness, there may be left ventricular hypertrophy, so there is left axis deviation. Now, in case of block in the anterior fascicle of the left bundle branch, anterior fascicular block, left anterior fascicular block in or hemiblock, inferior myocardial infarction. So these are condition, obesity, there may be left axis deviation. Now, right axis deviation, it is the normal variant, particularly in children, also may be found in young adults. So this is not right axis deviation may be found in normal person, children or young adults. Now, infarction of the lateral wall of the left ventricle. You see, left ventricular hypertrophy common in left axis deviation, but infarction of the lateral wall of the left ventricle, you get right axis deviation. In dextrocardia, in left pneumothorax, and left posterior fascicular block. Left posterior fascicular block. So left anterior fascicular block, you get left axis deviation. And left posterior fascicular block, right axis deviation. So these 2 points you must remember. So these are the conditions of this different ECG tracing. Okay.